Good morning, everybody. I am Professor Mario Marzilli from Pisa University, and it's my pleasure and an honor to welcome you to this webinar on, I would say, not just a new entity in cardiac medicine, but in a new era. Maybe you will find this word a little bit redundant, but later on during this webinar, I'm sure you will understand that by the relevance of the speakers and even more so for the relevance of the topic and the anticipation of the major changes in the approach to the leading cause of death in the world, that is ischemic heart disease, we are really in a very exciting and promising and challenging time of cardiovascular medicine. So welcome, thank you for joining us. And it's a pleasure to introduce the first speaker of this webinar, that is Professor Juan Carlos Kansky. Professor Kansky is an authority in the field of ischemic heart disease. He has contributed to the field with many, outstanding publications in most, relevant and prominent medical journal. And last but not least, he's a very good friend of mine, and I have a great esteem for Professor Kansky. So please, Juan, let's start with the first presentation.
Mario, thank you very much for these very kind words. And I'm really delighted and honored to be here today to talk about the pathophysiology of ischemia with unobstructed coronary arteries. I have no disclosures to make for this presentation. Let me start by sort of highlighting what is the current paradigm regarding ischemic heart disease. When cardiologists think about angina pectoris, that is almost synonymous with obstructive atherosclerotic epicardial coronary artery disease. And cardiologists think that the main cause for myocardial ischemia is obstructive coronary artery disease. And therefore, all the current diagnostic and therapeutic strategies for angina are largely based on this paradigm. And it's interesting that not only physicians, but also patients frequently view coronary artery disease, coronary artery stenosis, as a mechanical problem that can be fixed by mechanical means. And I hope that today, in the next 10 minutes or so, I will be able to show you that there is more, there is something beyond obstructive coronary artery disease to explain ischemic heart disease. Cardiologists are in general conversant with this sort of basic concept of coronary flow reserve, which essentially means that in order to meet the oxygen demand by the myocardium, the coronary arteries need to deliver sufficient amount of blood. It's a very simple concept. If there is an obstruction to the blood flow, say, for example, a very, very severe coronary artery stenosis, to actually use the paradigm, this flow reserve will be reduced. So this curve will actually move to the right and down to the point that the flow will be limited. And coronary flow, and this is important, is determined by the driving pressure, which is the diastolic blood pressure, and the resistance that the arterioles and compressive forces of the myocardium exert on the blood flow. And this is an important concept because it can explain how coronary blood flow reserve can be reduced even in the absence of any obstruction to the coronary arteries. And there is another concept that I would like to mention very briefly before I move on to the pathophysiology of INOCA, which is coronary artery spasm. In a way, the other end of the spectrum of ischemic heart disease. Coronary artery spasm, through an abnormal reactivity in a segment of a coronary artery, can actually reduce the blood flow very dramatically. And coronary artery spasm, as you know, can happen in normal or diseased coronary arteries. And very importantly, coronary artery spasm tend to occur at rest, usually in the early morning hours. It is not associated in general with effort-induced angina, and it resolves either spontaneously or with the administration of nitrates. And you'll see why this it is important to actually consider coronary artery spasm as another important component of the pathophysiology of angina pectoris. And now we're coming into a third issue, which is the fact that if there is a marked increase in the resistance to coronary blood flow at the site of the coronary microvessels, which are these vessels here, small arterioles and capillaries, that increased resistance can trigger myocardial ischemia, exactly as we see in patients with obstructive coronary artery disease with ST segment changes and myocardial perfusion abnormalities. And this can happen in the complete absence of coronary artery disease or in the presence of coronary artery disease. And I will come back to this concept later on. There are basically two key mechanisms explaining microvascular angina. In other words, angina triggered by abnormalities in the coronary microcirculation. The first mechanism is an impaired vasodilation. In other words, the arterioles cannot dilate properly. This happens when there is an inflammatory issue, when the endothelium doesn't work properly, when there is an increased inflammatory activity, when there is a release of substances like serotonin or histamine. And some people are very interested in the mast cells being associated with this syndrome of microvascular angina. So impaired vasodilatation. And this impaired vasodilatation acts in a way like a coronary artery stenosis, because the arterioles cannot accommodate the necessary amount of blood flow to supply oxygen to the myocardium. Very often we see this abnormal vasodilatation associated with conventional risk factors for coronary artery disease, hypertension, dyslipidemia, very importantly with estrogen deficiency, and also with chronic inflammations, as we see in rheumatoid arthritis, lupus, or mast cell disease. And the other big mechanism is increased vasoconstriction, which functions like the epicardial coronary artery spasm that I described before. Microvessels can go into spasm and limit blood flow quite dramatically. For many years, the microcirculation was elusive to our technologies to identify myocardial ischemia. But technological advances such as intracoronary pressure measurements, non-invasive imaging with positron emission tomography, SPECT, and magnetic resonance have actually shown that the abnormalities in the coronary microcirculation that contribute to the development of ischemia can be actually seen. And cardiologists are beginning to believe that this is a real entity, because they can now see that these changes are real. And I have no time today to go through the different types of coronary pathophysiological studies that can be done in the catheter lab or indeed with imaging techniques. But suffice it to say that we are now able to identify different subgroups of patients in whom there is just isolated microvascular disease, patients in whom there is a combination of obstructive coronary artery disease and microvascular dysfunction. And this is very important, like as Professor Marzilli will tell us later, in order to identify which is the right treatment for these patients. Very often, unfortunately, when somebody comes to the catheter lab to be investigated for chest pain suggestive of myocardial ischemia, everything stops after the arteries are shown to be normal, unobstructed. So in general, these patients are told there is nothing wrong with you. We've done an angiogram and your coronaries are absolutely fine. Forget about it. The pain is non-cardiac. Wrong, very wrong. We have shown in a study that we carried out with Peter Ong and Udo Sektem from Stuttgart a few years ago now, we decided to look at the coronary arteries of people with typical angina pectoris. And to cut the long story short, we found that 50% of these patients undergoing angiography for stable angina had normal coronary arteries. So we then moved on to performing an acetylcholine test to see whether they had coronary artery spasm or indeed any other abnormality in the microcirculation, and found two very interesting sort of prototypes. The first one is illustrated by this case, where the injection of acetylcholine triggered diffuse narrowing of the left anterior descending coronary artery, particularly the distal regions, and this was associated with ST segment changes and angina, and the administration of nitrates into the coronary arteries restored the diameter and eliminated the electrocardiographic changes and the pain. So this is a typical example of distal vessel disease, probably involving also the microcirculation. But look at this example at the bottom of the figure. This time we injected the acetylcholine and the epicardial coronary arteries did show any change in diameter, but the patient experienced the typical pain and the typical electrocardiographic changes. The administration of nitrate eliminated the pain and the electrocardiographic changes, and this is a typical presentation of coronary microvascular spasm. Microvascular spasm is of importance, mainly because it is linked to real ischemia, contractile abnormalities, and in some cases, increase in cardiac troponin, which means that the spasm has caused some damage to the myocardium. So that's why I believe that the investigations of the problem of INOCA should not end when the arteries are shown to be normal angiographically, but should start when that finding is identified. This slide summarizes the different mechanisms I mentioned briefly now. And we have the two ends of the spectrum: obstructive coronary artery disease, the current paradigm, and the other end of the spectrum, epicardial coronary artery spasm, functional mechanism triggering ischemia. But in the middle, we have a world of triggers of ischemia associated with microvascular abnormalities. These can be structural mechanisms, as we see in people with hypertension and another sort of cardiomyopathy and other conditions, where perivascular fibrosis, capillary rarefaction, arteriolar remodeling can reduce the blood flow. There are also, as I mentioned before, functional mechanisms leading to either abnormal vasodilatation of the microvessels or microvascular spasm. And very importantly, and very often sort of ignored, is the effect that the myocardium can have on the coronary microcirculation. Left ventricular hypertrophy, tachycardia, calcium overload, etc., can limit the ability of the microvessels to deliver blood flow. So, just to finish, to remind you that we are not talking about the dichotomy, coronary artery disease or microvascular angina. These situations can coexist in the same patient. So a patient can have an obstruction caused by an atherosclerotic plaque, but at the same time, microvascular dysfunction. And in many cases, the microvascular dysfunction is the reason for the pain. So, in this very brief sort of summary of the mechanisms of myocardial ischemia, and particularly INOCA, I think we have learned a lot of things in the past 10 years. And I think we can now draw the following conclusions. INOCA can be triggered by functional and structural abnormalities of the coronary microvessels. Functional mechanisms include abnormal dilatation and vasoconstriction. The clinical presentation and the coronary physiology studies that we can carry out now can identify the prevailing mechanism and can help us identifying rational treatments for the condition. And finally, coronary artery disease and functional and structural coronary microvascular abnormalities often coexist in a given individual. Therefore, we are dealing with a continuum of ischemic heart disease and not a dichotomy represented by either coronary artery disease or microvascular disease. Thank you very much.
Thank you, Johan. That was a fantastic summary of the pathophysiology of this condition. How we progress now? Do we have questions from some of the attendees that we can address right now? Maybe we, of course, starting with you.
There is a question in relation to the possible correlation between mast cells and microvascular angina. Indeed, mast cell disease, which affects some patients with microvascular angina, has a relatively simple explanation as to why it can trigger endothelial dysfunction, microvascular dysfunction, and even epicardial coronary artery spasm. The Kunis syndrome is one of the examples of this association. And we have published data a few years ago showing how many inflammatory conditions, many allergies, and immune diseases can affect the endothelium of the microvessels and trigger microvascular dysfunction. So certainly a clear relationship, and the treatment has to be directed to the basic reason for the inflammatory process or allergic process, and also to improve the function of the microcirculation. And I'm sure Mario will tell us a lot more about how to treat this condition.
Well, thank you very much, Juan Carlos. Of course, please don't leave, because there will be maybe question in the later on, and you are more than welcome to contribute. So then I think it's a great pleasure to introduce a big novelty in a medical meeting. Usually medical meeting see doctors and professors and maybe sometimes administrators or legislators speaking, but very, very rarely in medical meeting. There is a full acknowledgement of the relevance of the patient in this situation. Now patients are becoming popular because there is a new fashion in cardiology that's called shared decision-making. And by shared decision-making, it implies that some options must be discussed with the patient. Now, it's something very promising, something very challenging, unless it is interpreted as a way of sharing your responsibility with the patient in deciding which option to accept. Maria George is a very exceptional person, because she's not a doctor. She was a patient. She experienced what is myocardial ischemia. She experienced what is the journey of the patient across offices, hospitals, doctors, diagnosing tests, treatment, and blah, 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 blah. But of this personal experience, Maria has made a fantastic adventure that is called INOCA International. she built up from her personal, let's say, not very exciting, not very, let's say, nice story from a, let's say, medical point of view. She has triggered an incredible interest in the role of patients in medicine, not just cardiology. Please, Maria, you have the word, the talk, the microphone now.
Thank you so much, Professor Marzari. That was a lovely introduction. First of all, a huge thank you to everyone who's been involved in bringing this webinar together today. The patient perspective is such an important voice in the care conversation. So I do feel truly honoured to represent that patient voice here today. We thought it might be very helpful to take a look at what patients themselves consider to be the unmet needs of INOCA, and also what patients themselves expect and want from their treating physicians. So the presentation today is not an individual patient view. It represents the voices of patients in a worldwide INOCA patient support group, and also the very many patient views and concerns that we have been privy to at INOCA International. All patient views included have, of course, been anonymised or are included with permission. Coronary artery disease is a mechanism, traditional plaque-centered mechanisms of blocked arteries, as you can see on the screen, are still considered by many to be the main cause of myocardial ischemia, as Professor Kasky said. Yet around 50% of patients with angina or ischemia don't have blocked arteries at angiogram. So where is that ischemia coming from then? And why are so many investigations stopping, again, at the point of a clear angiogram, despite ongoing chest pain and despite ongoing symptoms of ischemia? Coronary artery disease is a mechanism of ischemia that has very effective diagnostics and provision, as we know. But at some point in the history and the development of cardiac care, there appears to have been a divide. Basically, a fork in the road where recognition, education and resources were all focused on one mechanism of ischemia, but not on another. Looking at the slide, in the case of coronary artery disease, the ischemia in that was visible. So it was full steam ahead for funding, for resources, for research, access approved. In the case of INOCA, the ischemia was invisible for the most part. So it was basically a no-through road. And this message was the same the world over. So whether it was about patients, about funding, about publication of papers, it was, for the most part, access denied. So effectively, the main trunk of the ischemia tree had somehow been split. So one side was given attention, provision, and was heard, but the other side wasn't. So one of the problems we now face is that we have not had the same benefits of INOCA. So we're now so far behind that we have a mountain to climb to catch up. And climbing a mountain can be hard work, but it still needs to be done. It's not okay to ignore and dismiss INOCA patients. It's not okay to send them home without treatment and care, and it's not okay to label INOCA symptoms as anxiety or mental health issues. It's also not okay to record those labels in a patient's notes because they potentially affect future care. Many INOCA patients report that they don't just feel unheard, they also feel invisible and forgotten about by most of the medical world. So patients need to know that they're not being ignored and that they are being heard and that they do matter. So what are some of the issues that we face as patients then? Well, we know that heart disease is the #1 killer of men and women. And we are told that ischemic heart disease affects around 3 million men and women in the UK alone. Yet INOCA patients often still struggle to get recognition or diagnosis or care. We know that INOCA conditions are under-recognised and under-diagnosed, and these are some of the problems. They're also under-treated, under-researched and underfunded, but they are also, we would suggest, underrepresented and under-recorded too. In the UK, each visit to a GP surgery or emergency department is logged under what is referred to as a read code. The read code is a numerical code which denotes a category for the condition you're presenting with or you're diagnosed with. And there is a specific read code for coronary artery disease, for ischemic heart disease, or even for Prinzmetal's angina. But unless there is a dedicated read code for INOCA that primary and secondary care staff are aware of, then this is yet another area where INOCA patients can fall through the net. If dedicated read codes for INOCA are not available and are not known about, then the very data being recorded, even for those who INOCA symptoms are recognised, they may still not accurately represent the numbers of INOCA patients seeking medical help. So if this is the case, the very data upon which the prevalence, the significance, and the provision of services for any INOCA-based service is calculated may also potentially be very underestimated too. So what's in a name? Well, the various names used to describe INOCA conditions have sadly only added to the confusion. Syndrome X, for example, is now considered to be an outdated term, but without one single name that we all agree on, ischemia from INOCA conditions is often thought of as odd or strange. But actually, the ischemia experienced in an INOCA condition is ischemia. It just has a different mechanism. So it shouldn't be being treated with any less care than any other mechanism of ischemia. The sad part is that ischemia from an INOCA condition has always been treated with less importance and with less significance. And INOCA patients and their families have all suffered as a result. So, in the words of one cardiologist recently attending an INOCA patient, the research for INOCA today is perhaps comparable with that in large vessel disease in the 1950s. And if that is the case, then we have an awful lot of catching up to do. We do have amazing medical professionals in our midst already. They have expert knowledge in INOCA and they're exceptional researchers, but we need more, we need many more. And those who understand the condition and who have a genuine interest in treating patients with INOCA. In the next two slides, two INOCA patients share a glimpse into their own journey, and they also in some of the real life consequences of that fork in the road, that division that happened in the ischemia tree all those years ago. So first, may I introduce Sally?
My name's Sally, and I've had microvascular angina for 7 years now. I was your average mum. I went to work, I had a busy job, I was on my feet all day long. I had two children who were also very busy, so I was busy running them to football matches and rugby matches and swimming lessons. I also ran a local community play group as a volunteer. So it was a busy life. And when I ran upstairs one evening, I couldn't believe I was getting chest pain. I had all the symptoms that I'd read, and I knew about heart attacks. I'm a medical professional. I've had training. I know what the symptoms of a heart attack are and when to be concerned. A bit sick, dizzy, lightheaded. By now the chest pain wasn't just in my chest, it was into my shoulder and down through my arm. It's like an elephant sitting on my chest. It really was a concern, and I really felt at this point I should be going to the emergency room. So I took myself there, as you do, and I expected to be treated with dignity and compassion. And I was quite surprised when I was told from the outset, after I'd had an ECG, that I was wasting their time. But they had to follow protocol. So they would do a few other things like an X-ray and do a blood test. And after they did those tests, I was given a lecture about how I'd wasted their time that morning and I shouldn't have gone to A&E and I shouldn't be there. And I was sent home, being told it's probably just indigestion. In my practice as a clinician, I'd never lecture people. I'd never be so rude as the rudeness I'd experienced. And I just couldn't face going anywhere. It felt like I was having a heart attack. And I felt I couldn't go and seek medical assistance because all I'd get was a lecture. When I was referred on to a specialist, I had cardiac perfusion, MRI, and then I had my diagnosis of microvascular angina. Some of the medications we've tried haven't quite worked. Also, the condition has slightly changed over the years. So even though I travel a long way, I think it's well worth it for that peace of mind.
Remember, Sally was a medical professional for over 30 years, and this was a hospital that she felt she was safe in. She'd worked at that hospital for over 15 of those years. Yet even as a medical professional, she was dismissed, and she didn't feel she could go back despite increasing heart attack symptoms. But Inoka doesn't just affect women. Next, we'll hear from Stephen.
My name is Stephen Miller, and I'm unfortunately one of the countless Inoka patients around the world. My journey actually started way back in 1992 when I was taken to a hospital as an emergency with a potential cardiac condition. It came back in 2000, and it was from then that I started to have the pain episodes and breathing difficulties almost continuously for the next 21 years until now. The final diagnosis of this debilitating condition took decades, I think it is fair to say. I was told there was nothing wrong with me. It was possibly in my head. It might have been a stomach problem. I had to see several cardiologists over many years, various tests on various different concoctions of medication. It took my current cardiology professor, I think, about 2 years of trial and error before I was on the medication regime that I am now, which comprises many different tablets. The main unmet needs for people worldwide who suffer from Inoka are, first of all, being treated as human beings with a medical problem, because very largely they are either ignored or made to feel that this condition is in their head. The lack of knowledge and understanding, not just amongst cardiologists, but GPs and hospital personnel, as to what Inoka is, and because they don't understand it, they tend to dismiss it. Given that Inoka does exist, the absence of any protocol and procedures from when you call an ambulance through to when you're seen by a cardiologist and their team as to exactly what to do. At present, from my experience, and I believe many others, what he's actually done is to rule out the most serious problems, quite rightly, of cardiac arrest or a heart attack. Once that's been done by the various tests, you are left to your own devices very largely, often then sent home, still in pain, but none the wiser. My hopes for the future is that in the medical world, everyone sings from the same hymn sheet. Inoka is a known, understood, treatable as far as possible condition, not something that we've brought here from outer space, as it seems to feel like. My hope is also that an otherwise excellent NHS and medical personnel generally in this country, where I've been very well treated and looked after, do expand their knowledge to include Inoka as a serious cardiac condition.
Stephen had Inoka symptoms for over 20 years, and yet until he was able to access an expert in Inoka, he wasn't believed. The sex disparity of care in Inoka is well documented in the Women's Health Plan of the Scottish Government, in the BHF Bias and Biology booklet, but men don't always get better or quicker care. Sally and Stephen both had to retire early from the careers that they both loved. And sadly, these are not isolated cases. Similar experiences are reported in the patient forum on a sometimes daily basis. And this is not just in the UK, this is a global problem. So looking at the unmet needs, what do patients say are those unmet needs? Well, as you can see from the next slide or this slide, patient response around unmet needs centered around 7 main areas. They focused on longer initial appointments to review additional symptoms and fully answer the questions, regional access to specialists and tests to avoid long distance traveling, acceptance and awareness of Inoka as a recognized cardiac condition, appropriate testing with challenge cath available as an early option where appropriate, research, development medications, a commitment there to ongoing research and funding, inpatient, outpatient care for protocols for A&E, GP, ambulance and hospital staff, named cardiologists with a special interest, if at all possible, and regular follow-ups. And also the revision of or review of policies and guidelines, because, for example, the NICE 95 sign guidelines prioritize CT angio, but in a cost-constrained healthcare system, a negative CT angio is often followed by discharge. And this stenosis-centric approach of No blockage equals no angina. No angina equals no access to services. That's continued through medical education and through research too. But as Professor Kamichi pointed out at the INOCA International Meeting of Minds, a clear angiogram should be the start of the investigative journey, not the end of it. So what are the patient expectations then? Well, from their treating physicians, belief, understanding, acceptance and respect, all of those came high upon the list, as did an expectations for doctors to be up to date with INOCA knowledge, a willingness to refer on, to consult with other doctors and teams where needed, and for doctors to take notice of existing patient care plans, and especially in the acute care setting. We recognise, of course, that the last two slides might seem like a very long list to resolve. And even these lists are not exhaustive ones, but many of those unmet needs and expectations of INOCA patients actually just come down to 4 very important points. Listen to your patient. Learn about INOCA. Refer on where appropriate, and recognise that the management of INOCA conditions can be lifelong, and that INOCA affects other areas of the body and may need a multidisciplinary team to address any comorbidities. Patients themselves already know that INOCA conditions can be difficult to treat and to manage. They also know that they can be time-consuming and they can certainly lackluster, but that doesn't mean that patients don't need treating. INOCA management often finds itself in the hands of interventional cardiologists too, but it also belongs with non-invasive cardiologists and clinicians, because most cardiac conditions require lifelong management, and INOCA is no different. So what lies ahead? Well, we need robust scientific evidence in INOCA, and this can only come from research. So we do need research, but research needs funding, and funding will only come if the funding bodies and those who feed into them are fully aware of the prevalence of INOCA. And that prevalence only becomes visible when INOCA is recognised, is diagnosed, and when the data is collected and correctly coded at source. There have been significant advances in technology, of course, but access to specialist testing is not always available or even possible. There is also a level of expertise needed to interpret results from specialist tests, but again, experts in INOCA are not found in every local or even every regional hospital. So when the true numbers of INOCA patients finally come into view and that wall of invisibility comes down, we may well face a tsunami of INOCA patients who have up until that point been hidden behind that wall, and some of them for years. We can't then ignore them any longer, so we need to be as ready as possible for when that wall does come down. We can't fix everything with one webinar, but what we can do is commit to change with a genuine determination to do better. So the decision is simple. Do we continue to do the wrong thing in the hope that all of this will go away? Or do we now choose to do the right thing? At INOCA International, we continue to work to raise awareness and further understanding of INOCA with a view to improving patient care. But there's an awful lot to do to bridge a gap of 70 years, so we all need to do our part. With over 30,000 visitors to our website and over 2,500 followers on Twitter, with a quarterly INOCA newsletter which is distributed worldwide, and the ability to be a listening ear to the patient voices in an international INOCA patient support group, our global INOCA voice is heard across the world, but each individual voice matters too. So I know that many patients listening to this webinar will have personally experienced a lack of understanding and knowledge in INOCA. And this just further confirms the journey that still lies ahead of us if we're to address the unmet needs of INOCA, but we have to start now. So I will end my presentation today, thank you, by sharing a very short video about INOCA International. And I invite you all to join us in committing to raise awareness and to further understanding of INOCA, with a view to improving care for all those INOCA patients who have already waited far too long.
Welcome to INOCA International. We are a unique partnership where doctors and patients work together to raise awareness, to further education and to improve care for patients with INOCA. we are supported by a truly outstanding medical advisory board, where everyone involved gives their time and expertise free of charge in a joint and determined effort to improve understanding. Our first ever meeting of minds was a huge success, with knowledge being shared openly by patients and medical professionals around the world. Expert presentations, Q&A sessions, patient displays, and a global sharing of information. We believe we are making a difference in helping to bring attention to the unmet needs of Inoka and in improving the lives of patients. For more information, come visit our website at inokainternational.com.
Well, Maria, this was really a fantastic, impressive presentation. And many of the concepts you anticipated are an exciting challenge for all of us. Can you see my slides? Can somebody confirm me that my slides are visible to the audience?
Mario, are we going to discuss Maria's presentation now, or that will be at the end?
I think that at the end it will be after my my lecture. It will be more constructive and open.
Okay, so may I introduce you then?
Please.
Okay. Well, I mean, Professor Marsili needs no introduction, but let me tell you that apart from our friendship that goes many, many years, Mario has been one of the most influential thinkers in terms of ischemic heart disease. His work has stimulated research in different areas, and his indefatigable fight against the wrong paradigm actually needs to be recognized. And I think Mario's work is actually responsible for the changes and the positive changes we are seeing now in the understanding of ischemic heart disease. So it is a great pleasure, Mario, to introduce you to this audience today. And we are very eager to know how we should treat or manage Inoka.
Thank you, Johan. I'm very excited today. As Maria said a few minutes before, at some time in history, there must be a change. And maybe this is the time for changing in cardiovascular medicine and in ischemic heart disease. But before discussing, let me present some perspective, historical perspective, in this, in our understanding of myocardial ischemia. And then we will conclude, of course, how can we manage myocardial ischemia. Well, my first concept is the importance of being earnest. Unless we admit the limitation of current conceptions or misconceptions, until we don't admit that ischemic heart disease is a very complex condition and there is no universal solution for it, we will not make the progress that is so desperately needed, as Maria anticipated. And let me just let's say that there is a very stubborn reluctance of the medical community to accept scientific evidence. This basically, Johan, is the summary of the traditional conception that you presented in your lecture. And this is signed by a very important cardiologist, Dr. Peter Libby from the Harvard Medical University. And it was published in 2013. So only, let's say, 8 years ago on the New England. And once again, there was the repeated concept that everything goes back to coronary atherosclerosis, that may grow progressively in time, may grow suddenly, but everything goes back there. Please note that several years before, 3 years before, there was a publication on the same journal, the New England Journal of Medicine, summarizing the data of the American registry. That means more than almost 400,000 patients, when the presence of ischemia based on non-invasive testing was compared with the coronary atherosclerotic obstructions. And as you can see from this cartoon, there was no difference in the prevalence of coronary atherosclerotic obstruction between patients with positive, the left side, or negative test. So there was no difference in the prevalence of coronary obstruction between patient with documented ischemia and patient with no evidence of ischemia. This other study, published 2 years before that paper and published in Circulation, looked at angina. And the assessment here was done with angiotac, I mean, the very popular today diagnostic tool, TC angio. Well, compare the blue columns with the yellow columns. The blue columns is what the misconception predict, that if you have typical angina, you have a lot of coronary atherosclerotic obstructions. Well, once again, the yellow column show you that there is no difference in the prevalence of atherosclerotic obstruction between patient with typical angina, to the right of this cartoon, or patient with no symptoms whatsoever, to the left. This is only part of the study. This was the male gender, 7,000 patients. In the same study, in the female genders, the situation is even more striking. Not only there was no difference in the prevalence of coronary atherosclerotic obstruction between asymptomatic patient and patient with typical angina, not only there was a marked, inconsistency between the expectation of the guidelines of the official theory and the reality. Look at the right, the blue column that anticipated a 90% prevalence of obstruction in patients with typical angina, and the yellow column, what was observed in reality. But as you see, in the female gender, the prevalence of coronary atherosclerotic obstruction is much lower than in the male gender. But we all are aware that in the women, ischemic heart disease is at least as common as in male, and at least in the acute coronary syndrome area has a worse prognosis than in male. So no association between coronary atherosclerotic obstruction and presence or severity of myocardial ischemia. Now, we, and you know some of the authors of this paper, summarize in 2012, before that publication by Dr. Libby, that the link between coronary atherosclerosis and myocardial ischemia is much more elusive than commonly considered. And we presented this cartoon where you see it in the center, the myocardial ischemia. Maria said, ischemia is ischemia, exactly. And you see all around ischemia a number of possible precipitating mechanisms. This, when I prepared this cartoon, somehow it came to my mind the word Copernican revolution, just to make a little historical, you know, for centuries, the humankind was sold on the idea that planet Earth was the center of the solar system, with everything else rotating around the Earth, including the sun. It took 2,000 years before Nicolaus Copernicus in 1543 published a paper saying that no, at the center of the solar system, there is the sun, and the Earth is just one planet rotating around with many others. So at the center of our profession, there should be myocardial ischemia, and the number of mechanisms must be still fully discovered. Now, we made, there's been a great novelty in the recent guidelines, because there were these figures published there. where you see that there is an official recognition that the prevalence of coronary obstruction is much lower than expected. If you focus on the left in the typical angina patient, a minority of patients, only a minority of patients does present with a coronary atherosclerotic obstruction. 1/3 in the male gender and almost as low as 1/10 in the female gender. And these figures have been reproposed again on the other side of the Atlantic Ocean in these guidelines on chest pain by the American Heart American College, where once again, you see that the prevalence of obstruction in patients with cardiac chest pain is very low, much less than expected or predicted. And interestingly enough, in this, again, very recent publication, there are, I mean, not for me, but for most cardiologists, a surprising information that the prevalence of coronary atherosclerosis in the general population detected by, again, by CT angio is higher than in symptomatic patient, than in patient with angina, in patient with myocardial ischemia. So these are the figures and the number. I don't want to go into detail. So, but let me just summarize this information. Most patients with typical angina simply do not have coronary atherosclerotic obstructions. Second, most patients with coronary stenosis do not have angina pectoris. So this is, surprising. And the other misconception is that non-atherosclerotic ischemia, even when accepted or diagnosed, is regarded as a sort of lower level of ischemia. It's almost like a funny variety. Well, again, the evidence says the opposite. This is a publication on the American Heart Journal in 2011. This is an autoptic analysis of the heart of patients dying in hospital because of myocardial infarction. And the surprise is that the largest group, 38% female, 23% male, had no visible atherosclerotic obstruction, visible to the eyes of the pathologist. And it has been somehow underestimated, the message of this publication from the Danish registry of the European Heart Journal. Well, as you can see easily from these Kaplan-Meier's curves, the outcome of this patient is dictated by the presence of angina ischemia, not by the severity or extension of coronary atherosclerosis. You see a number of curves in this cartoon. The message is that there is one curve that is much shallower than the others, and those are the asymptomatic patients. And then there is a number of superimposed curves with 1, 2, 3, 0 diffuse vessel disease that have symptoms. So once you have symptoms of ischemia, you have a worse outcome than when you don't, regardless of the severity of myocardial atherosclerosis. I borrowed this, actually, there is a misquoting here, it's not Levy. Actually, Dr. Levy copied this cartoon to the left from a publication, from a publication of Juan Carlos that deserves all the credit for this, listing a number of possible precipitating mechanisms of coronary ischemia. And that includes coronary spasm, includes, of course, occlusive coronary atherosclerosis. Coronary microcirculation, as he anticipated, has a major role. But maybe I like to mention that Dr. Carl Pepine, a very expert in ischemic heart disease from the United States, added non-vascular mechanisms, so metabolic mechanisms, mitochondrial mechanisms, cellular mechanisms to the possible list of causes of myocardial ischemia. And this, again, is how complex is the scenario cardiologist and patient have to face. And now, let's go to the final part of this presentation. How do we manage myocardial ischemia? As you notice, or you may notice, I didn't wrote management of INOCA. I wrote management of chronic ischemic syndromes. Because as Maria said, probably all these terms, INOCA, coronary artery disease, Prince metal angina, microvascular dysfunction, may just add confusion. These are the words she used, and I really like that. Ischemia is ischemia. We have to manage chronic ischemic syndromes, and we have to approach the problem in a rational fashion. The first step is to be sure that the patient does have an ischemic condition. So we have to diagnose ischemia. But it is surprising today the emphasis of the guidelines on coronary anatomy after all the data I have presented you that have been in front of us for a decade or more. So the diagnosis of myocardial ischemia must rely on the signs and symptoms of myocardial ischemia. And we have several options. We have the quality, all the characteristics of the chest pain as described by Aberdeen more than 2 centuries ago. And then we have the classic EKG changes in the ST segment or the T wave. We have at the echo regional and transient and reversible wall contractility performance changes. We have changes in myocardial perfusion. We have lactate production. So we must rely to diagnose myocardial ischemia on the manifestation of myocardial ischemia. And when we have concluded that, yes, this patient is suffering of myocardial ischemia, we can make, and actually we should make an effort to identify the precipitating mechanism, why this patient does suffer of ischemia. And once again, medical history can be extremely useful in this approach. The simple, careful history taking in a patient. Just let me present you some example, very simple. If a patient comes to you telling, doctor, every time I run more than 200 yards, I have to stop because I feel pressure on my chest. But in a few seconds, it fades away, and then I just can walk again. This is very suggestive of a obstructive myocardial ischemia. If the patient to the right tells you, I can do anything I want, but then maybe while I'm sleeping, while I'm waking up early in the morning, as Juan Carlos anticipated, I feel a tight pressure in my chest. That after 2 or 3 minutes goes away, and then I can do whatever I want. I can jog, I can run, I can climb stairs for the rest of the day. This is suggestive. Of course, not conclusively, but suggestive of a vasospastic form. And then we have patients that refer an unpredictable threshold for angina. Sometimes they have angina while exercising, sometimes at rest, at variable threshold or variable level of exercise. This is quite suggestive of a microvascular dysfunction behind this manifestation. And then we come to how can we cure this patient? Of course, we have to consider that available agents have different mechanisms of action. We all know what beta blockers are expected to do, what calcium channel blockers are expected to do, what metabolic agents are expected to do. And we have to select the drug according to the documented or presumed mechanism of ischemia. And we have also to always keep in mind that this is a long life condition. Does not go away in a week or a month. So not only efficacy, but clinical tolerability is a very important characteristic in this choice. And then, of course, we have to consider that we are not just treating myocardial ischemia. We are treating myocardial ischemia in a patient that may have heart failure, may have arrhythmias, may have diabetes, may have hypertension or hypotension, or so a number of conditional comorbidities that must be considered in the most appropriate prescription to these patients. And we have an option, if I can go back, okay. in this growing number of possible mechanisms that can cause angina, we don't have tools or dedicated agent for all of them. So probably a smart move will be to focus on agents, and we do have them, that instead of trying to prevent, or in addition to prevent the ischemic episodes, may protect the cardiac cells from the possible damage during ischemia, irrespective of the precipitating mechanism. This will, in my perception, probably be the master's choice in the future in the management of these patients. Still, we have to focus a number of burning questions. We don't have the full list of mechanisms that can be responsible for myocardial ischemia. And we don't have appropriate stressors to identify all the possible mechanisms. And these are the two main challenges for the next generation cardiologists, because I'm afraid Juan Carlos maybe is younger than I am, but we don't have all that time to promise that we will clarify all these things. And that is be the precondition to give to each patient the most appropriate treatment. And not just a patient with INOCA, CAD, but a patient with the chronic myocardial ischemic syndrome. Thank you very much for your attention. I will stop here for the moment.
Thank you very much, Mario, and thank you very much, Maria, for excellent presentations. I think we're ready to initiate a discussion, which you will be chairing, Mario, but I would like to start by saying that Maria's presentation is such a good representation of the awful situation that many, many patients actually face when consulting cardiologists around the world. I am saddened every time I hear this sort of stories of doctors not believing in coronary artery spasm, not believing in this or that, as if this, as you were talking about, religions and not science. And Maria's presentation also highlighted something very important, which is the real need for shared care. Patient is at the center of our actions and should be at the center of our actions, and not a passive part of the interaction, but a very active one. So I think that what we are doing today should be probably become common practice, but particularly during the medical consultation. I think we have a long way to go, and this road has to start now, because otherwise, I mean, we'll take like the Copernican revolution before we see a real change, and patients need this change to happen now. And cardiologists also need to start reading a bit more about what, just move away from the comfort zone of coronary artery disease. Anyway, I wanted to say this before starting the discussion.
Okay. Need an icebreaker? Maria, do you mind if I said not to use the word INOCA in the future, just to say myocardial ischemic syndrome?
I think that's a very good point to make. And I love the fact that we're talking about ischemic syndromes, because it's not all about INOCA. It's not all about coronary artery disease. You know, my view is there are lots yet that we don't know about, I would suspect, and a lot of mechanisms of ischemia that are yet to be discovered. So I think we have to look at it as an umbrella term, as you say, as ischemic syndromes, and not as individual tags of coronary artery disease or INOCA or any other mechanism.
And in addition, I think the problem with actually trying to identify or give a name to these syndromes or clinical presentations, the risk is that we really lose track of what the condition really is, and we are dichotomizing between obstructive coronary artery disease and non-obstructive coronary artery disease. I mean, there is no point really in doing that. I think we need to try and put the ischemic syndromes in the big context under the umbrella of ischemic heart disease, and this is the only way in which we are going to make progress, really. But I think identifying, I mean, in a way, it is good to talk about INOCA because it has helped focusing a little bit more on the concept of ischemia triggered by mechanisms other than obstructive coronary artery disease. I mean, in a way, it has helped. It's a way of understanding the concept, and sometimes physicians need that help.
I have a couple of questions on just written question, Juan Carlos. Maybe one was referring to any benefit to use trametinib in acute myocardial infarction setting. I don't know if this question is very appropriate because none of us has discussed acute myocardial infarction. No. But if the person who put the question is interested, there was a trial in the 90s that was called EMIP-FR, European Myocardial Infarction Project, and they can read the conclusion of that trial on the European Heart Journal. There have been several papers on that. Yeah. And there was also a question on the response to adenosine in the cath lab.
Yeah, I replied to that one in writing. I don't know whether everyone can see the response, but anyway, I think it is an interesting question. Coronary physiology studies are absolutely critical for this. So, as I was saying before, the study cannot stop in the cath lab. It usually starts in the cath lab. And the possibility of identifying the different presentations is important. And the adenosine is a valuable tool. Many people, both interventionists and patients, are put off by the fact that there are lots of stories, frightening stories about adenosine causing bad pain and drops in blood pressure. I don't think that is so frequent. And Mario, I'm sure you in your interventional experience, have had these cases, but I think that we see occasionally adenosine causing bad pain, and adenosine is a pain mediator, so you expect some chest discomfort with adenosine. But in people with microvascular angina and increased pain perception, the response can be more serious, but it's a good way of identifying the problem. And as for blood pressure drops, I think the rate of administration of adenosine is important, and in a few cases with severe microvascular dysfunction, the effect can be a drop in blood pressure, but it's not such a common phenomenon, and it's not something that should put people off from doing those studies. Mario, I would like to hear your views on that.
As you know, I've been using a lot of adenosine testing in my patient in the cath lab. And regarding the pain, in our experience, there was something funny in the sense that I never triggered chest pain by injecting adenosine inside the coronary. But I had some case of chest pain but with the IV, the peripheral injection of adenosine. Actually, we decided, this was only one of the reasons, of course, not the main reason why, when invasively studying the patient, to always inject adenosine inside the coronary, not IV. And this is because adenosine is a very powerful vasodilator.
Exactly.
But its effect is not by no means limited to the coronaries.
Exactly.
Vasodilate everything. So if you inject adenosine inside the coronary, you can inject a very high dosage without interfering with systemic pressure. This has two major advantages. The first one is that you never get hypotension. But the second one is that you don't interfere with aortic pressure anyway. And the flow that you measure after adenosine is a pressure-dependent flow. What you measure at rest is pressure-independent because of the autoregulatory property of the coronary circulation. But in maximal vasodilation following adenosine, coronary flow becomes pressure-dependent. So if you reduce at the same time the aortic pressure, that is the pusher of the blood in the coronaries, you underestimate the peak flow and you underestimate the coronary flow reserve.
Yeah. When I reply to that, I also mentioned the way in which you administer adenosine is important, and I was referring to that because you are bound to have a drop in blood pressure through peripheral vasodilatation, but if you avoid that, the pain though can happen when you inject intracoronarily, and we see this pain being more severe in patients with microvascular angina and increased pain perception. But
the most severe pain I observed is anecdotal code was in patients who had no dysfunction. Patient with no evidence of microvascular dysfunction or whatever, some of them refer to sharp pain.
Mario, can I just take you, and I think Maria will be interested in this as well. I have several questions asking for, I mean, are we seeing new agents coming through? What is the expectation for patients in terms of an improvement in our armamentarium, which at the moment is relatively limited? I want to say two things. The first one is that although the current armamentarium is limited, it is very useful if we use it properly. There is no point in actually giving what is conventional treatment to every patient with chest pain. We need to identify the mechanism. So if somebody, as you were saying, tell us that there is an increase, the symptoms appear on exertion and almost consistently, then the right medication would be to try and reduce the heart rate, reduce demand, as we do in people with obstructive coronary artery disease. If on the contrary, the symptom is occasional chest pains at rest or combination variable threshold angina, then you would use a vasodilator. And then in any case, you would use drugs like trimetazidine or ranolazine to reduce ischemia by allowing the microcirculation to work more efficiently. So limited armamentarium, but very useful if you use the right medication at the right dose in the right patient. And there are some new medications. I mean, Japan has Rho kinase inhibitors in intravenous form to administer to people with acute episodes of coronary artery spasm. And I know that there's been some sort of investigations, and they are ongoing on the oral use of Rho kinase inhibitors. But surely now that people are more interested in microvascular dysfunction as a cause of ischemia, we are going to see, I think, relatively rapid development, new agents coming through. I don't know whether you have access to some new information in relation to this.
This is a very important point because I don't want to be too, let's say, strong, but we are really at time zero. All we know about medical therapy of ischemic heart disease is based on studies where patients were all dumped together, irrespective of the mechanism responsible for myocardial ischemia. And most patients with myocardial ischemia were not included in the study just because they had no obstruction in the study in the angiography era. With one possible exception, vasospastic angina. The only study in selected and homogeneous group of ischemic patients have been conducted in vasospastic princemetal angina patient. And that's where the calcium channel blockers have been proven to be effective, not in other forms of angina or ischemia. But so I think we really have to start all over again saying, let's see what benefits a patient with a 90% coronary obstruction. That's where maybe beta blockers or ababradine reducing the heart rate may prove to be beneficial more than others, and vice versa. But then we also have to consider that currently available agents have two different, let's say, approach. Some agents, like again, calcium channel blockers, are expected to prevent the vasospastic episodes. So to prevent the exposure of cardiac cells to myocardial ischemia. Other agents, and I can name trimetazidine, ranolazine, are intended to protect, to limit the damage to the myocardial cells from myocardial ischemia. So the rational combination is one of these two protective agents plus a pathogenetic, let's call it this way, or a hemodynamic agent, if you identify the mechanism.
Yeah, well, exactly.
This is just speculation, though, I admit that.
Yeah, well, we discussed with Maria this many times. I think we're at the point. I mean, we cannot wait for the studies to appear before giving treatment to the patient. So
yes.
We have to use what we have now, and
Yes.
I think that if we use what we have now in an efficient way, then we can benefit many patients, because we are able to improve quality of life. We're able to reduce the effort-induced pain. We're able to reduce the episode of microvascular spasm. So I think that but the problem is that this is not something you take off the shelf and say, well, take this and things will go away. It is a crafty business. We need to actually start with a low dose, because many patients have a drop in blood pressure. So you need to start very slowly. You have to be patient. That is the reality. And these days, doctors have to see too many patients in an outpatient clinic, so they cannot actually devote time to think much about this or to start with low doses. So unfortunately, we need to change the culture. These treatments need to evaluate a number of things, and unfortunately, there is no single magic bullet that one can actually use. We have to be careful, patient, and understand the mechanism. I think that is, to me, the key to the success of the treatment. And also,
may I add a couple of points too?
Yes, please, Maria.
Sorry, Professor. On the side of the adenosine and on provocative angiograms and things like that, patients are actually eager to have those. It's the lack of availability. So although we do hear about patients being nervous about the drugs that are used, I think the overall summary that I could give back to you as feedback is patients want those tests. It's just they can't get to them, or they can't have access to them. And on the medication side of things, I think one of the things that has fed back increasingly is an allergy to medications or allergic reactions to medications. Quite a number of patients in the forum seem to feed that back. And on availability, ranolazine, for example, you mentioned, Professor Marzilli, and ranolazine is difficult in a few ways for accessibility. In Canada, it's just about approved, I believe. And in Australia, it's not available at all, I believe. So it's incredibly difficult because the medications that people are saying might be helpful are very limited in some of the other countries as well. So I think that's also something to consider too.
Yeah.
I think Carlos said a very important word. I'm referring when you once said doctors must exit the comfort zone. They are very reluctant. They are very reluctant to abandon, let's say, lifelong paradigms. They are very reluctant to enter a new unexplored territory. But it's no longer acceptable. Obstruction, yes, you are ischemic. Obstruction, no, go home and relax. It's no longer possible.
Yeah.
I understand that it's much more demanding, it's much more complicated, but it's the only way of going. It's time zero, but there is a time where things must change, and I agree with both of you that this time has come for ischemic heart disease.
There is one question here, which I think two questions actually, which will be of importance. And one is about any particular regime for women with a positive exercise test and tortuous coronary arteries, and I presume slow flow syndrome. Do you have any recommendation? Do you use beta blockers in those cases? Do you use diltiazem? Do you combine those with trimetazidine or ranolazine?
This is a very tough question, because if the slow flow, that does happen to see it in the cath lab is associated with increased microvascular resistance, then I would strictly avoid beta blockers for their vasoconstrictive effect and favor possibly a calcium channel blocker. But you may remember, Johan, a paper I published several years ago with Gianmario Sambuscetti and Antonio Labate showing how important can be rheology of the blood, platelet function in modulating microvascular resistance to flow. And this is a therapeutic target that has never been really addressed. In the past, because I am the oldest one said here, there was a popular medication for angina patients in Italy that was called dipyridamole, Persantin. And it has been abandoned for the lack of evidence because no study has ever proved the benefit. But I'm sure that there are patients where platelet thickness can contribute to macrovascular resistance. And if you can attenuate this problem, you can improve myocardial perfusion. As a matter of fact, coming back on a scientific ground, in acute coronary syndrome, an intracoronary administration of a very powerful antiplatelet agent that is abciximab, this was published on Circulation, dropped the microvascular resistance by 30% below the level achieved with an intracoronary massive dose of adenosine.
Yeah, so that's another important component.
This is one other possible mechanism that we ignore completely.
Yeah, and there is here's another question which I think is very, very important, and I will read it and answer, and then I would like to hear from you and Maria if you want to make a comment. But says, how long before we can consider repeating coronary angiography? No need to repeat angiography. If you're
to do coronary angiography,
to do coronary angiography, no need for it. Absolutely no need to except that you want to repeat the angiogram to do an acetylcholine test. And unfortunately, like coming back to Maria's point, not many centers are doing acetylcholine testing for coronary artery spasm. And I think that's a shame because once the patient is in the cath lab, that's a great opportunity to actually make a diagnosis of coronary artery spasm and then give the right treatment to those patients. But no, yes, no need for angiogram, no need to repeat the angiogram in these cases.
I can be very, strict. Coronary anatomy does not predict myocardial perfusion. We have to accept this. We have to be honest. We have to be, let's say, open and transparent. Coronary anatomy does not predict myocardial perfusion.
Yeah,
there is overwhelming evidence. You can do whatever you want. It's so easy to look in the coronaries, but it's like looking in a house by the keyhole.
Yeah, yeah. Maria, what is your, from what we are discussing now and your experience as a patient and your experience as a founder of Inoka International, you listed a number of things that need to happen in order to actually get patients better identified and treated. How can we influence the way things happen?
It's a very difficult one. It's a very difficult one. I think from the past, it's always been a case of from top down, and people have made decisions effectively in the boardroom of cardiology, but when it hits the ground and patients, in effect, it doesn't always come down as it's expected to have done. The intentions are always good and the plans are always really sound for the most part, but when patients actually try to get treatment, they're blocked in so many ways. If they go to a GP and the GP doesn't understand it, that's the first block. If they get past the GP and need to see a specialist in the hospital, they may not understand it. If they then ask to be referred out of the area, it's reported in the forums so often. They've hit the level of clinical commissioning groups, and of course they don't understand it either. So they refuse the referral onward. So we have a whole bank of patients who are waiting to be seen, waiting to have expertise, waiting to have specialists in Inoka guide them, and that can't happen because there aren't enough specialists.
Yeah.
So I think the answer is we need to obviously disseminate information, that's a given. I think we need to have something in place whereby there can be an access to information for people who don't have it, but to actually work from the ground up too. You know, it can't just be one direction. It has to be symbiotic. It has to be helpful to all.
Yeah. Thank you for this. There is a question by Dr. Fatari saying, what do you think is the best diagnostic test, I presume, to identify ischemia triggered by microvascular dysfunction? CMR, SPECT, positron emission tomography, calcium scores, CTCA.
Can I make a comment on this question? We are, again, in the middle of a confusion. And the confusion is that different imaging techniques are not different testing modalities. I mean, you can look at ischemia with EKG, with an echo, with a magnetic resonance machine, with a CT. You can look at ischemia with many tools, but the question is, how can you reproduce ischemia? So the technological, let's say, advance is not a cultural advance. And again, imaging techniques cannot substitute the lack of knowledge of the mechanism, the lack of appropriate stressors. If I suspect a vasospasm, I have acetylcholine or ergonovin. If I suspect a problem in vasodilating capability, I have adenosine. But if I suspect a platelet dysfunction, a platelet thickness, if I suspect a mitochondrial dysfunction and the production of ATP, and if I suspect in the microcirculation, not just in an appropriate vasodilation, but in appropriate vasoconstriction, how can I prove it? And
but
when,
Mario, sorry to interrupt, but you're making it very difficult the way you're replying to it. I think the question can be answered more easily, because I think people want to know, if I have somebody with chest pain, what do I do? Do I do an angiogram? Do I do an echo? And then the answer you give is perfect. He says, okay, depends on what you suspect. You need to trigger the ischemia. Can you trigger the ischemia? Fine. Then use the trigger which is correct for ischemia. Then can you image ischemia? Well, use the imaging modality that you have available and you trust most. So, but you have to actually diagnose ischemia and then image the ischemia properly. So I think that any of the things that we're asked about here, cardiac MRI or SPECT or PECT or not the angiogram, not the calcium scores, but the functional ones, they're all suitable, provided, as you were saying, you give the right stimulus.
this is the limitation we have today.
Yeah.
One of our professors said, if you'll forgive me interrupting, not too long ago, a patient had every single test in the book apart from the correct one. And that often happens. And Inoka patients have lots of angiograms, which we were just discussing before. You know, they're not, the cost to the NHS is huge. If they saved on all of these excess tests and all of these inappropriate stressors, I'm sure we would have more money to.
Let me make a very simple example. So maybe you are, Carlos, will forgive me for being too complicated. If you have a functional component in the ischemia of a patient, you can test on the treadmill for 1 week and it will always be negative. But this is not the problem of ischemia. It's a problem of inappropriate testing, maybe misleading. So when you say, I gave acetylcholine and nothing happened, it's not the patient does not have ischemia. It does not have ischemia associated with the vasoconstriction.
Yeah.
This is the limitation. And it's irrelevant if you look at ischemia with a scintigraphy or resonance, magnetic resonance or whatever.
I don't know if I'm the timekeeper or you are, but I think we are actually getting to the end of the meeting. I mean, if you want to close the meeting, Mario,
Well,
I have to say that it's been a fantastic experience, and I'm delighted to
I'm
have.
very happy. I'm very excited, and I'm much more optimistic for the future than I was a few months ago. I think this joint effort of patients and, let's say, open-minded cardiologists is possibly the key to stimulate that cultural revolution that is needed, because we really need a change in the culture of cardiology, not cardiologists, in the culture of cardiology, because this affects both doctors, patient, legislators, scientific society, everyone. Just open your eyes, face the scientific evidence, and be consistent with it. This can be, and the patient have a large, prominent role in achieving this, let's say, this dream, because at the moment it's a little bit a dream.
Absolutely, absolutely.
So,
It's been a great pleasure, and thank you to the audience for taking part, for the fantastic questions. And I'm sorry we were unable to answer all of your questions, but maybe we can reply to you.
We promise to be back. We promise to be back.
We will do
I don't know when and where, but we promise to be
Okay.
back.
Yeah.
Okay, bye-bye now.
Thank you.
very much.
Bye-bye.
Thank you very much, Juan Carlos. Thank you, Maria. You have been fantastic.
Thank you.
You have
My
been,
pleasure.
thank you.